Thank you so much, Dr. Lanford. That was outstanding. It's now my pleasure to invite Dr. Adam Christopher to the podium. He'll be talking to us. He's an associate professor of pediatrics here and the director of our cardiac MR and cardiac CT program at Children's Hospital of Pittsburgh, and he'll be talking to us about cardiac MR outcomes.
Thank you, Laura, and thank you to the organizers for inviting me to speak today. I'll start as well with a thank you specifically to Dr. Yu and then Dr. Olivieri for setting me up to understand what really the strength and limitations are of cardiac MRI in this application. I want to specifically, though, focus on what we can learn from comparing MRI before and after the cone procedure that might help us prognosticate or predict what can happen long-term for our patients. So I'm going to start that here with a discussion of a patient I follow clinically, a patient who presented for this scan at 12 years of age, notably has Epstein anomaly. She also had Wolff-Parkinson-White and had already one EP study with recalcitrant SVT. And so for her pre-op CMR here, we can certainly appreciate the displacement of the tricuspid valve here. We estimated, with the caveats and limitations we know of about tricuspid regurgitation here, at least moderate TR with a regurgitant fraction of 30%, normal right ventricular ejection fraction, and certainly some dilation of the functional right ventricle that we can appreciate in both views here. I considered myself very lucky to be able to tell this family in clinic that they were living right beside the Epstein, the De Silva Center for Epstein Anomaly, and we had the ideal repair for them. But the questions they had about long-term results and how close their daughter's heart would be to a normal heart, say 5 years, 10 years from now, I couldn't fully answer. I think we have a lot of data that I hope to dive into here and help explain, but it's certainly an ongoing question for the field. So what has CMR taught us about post-cone remodeling? I'm going to just go through some international results. We'll talk about some of the mid to late term remodeling effects, and then talk about a couple of interesting, unusual but interesting cases from here in Pittsburgh. So first off, I want to start with this paper from 2014 in the European Journal of Cardiothoracic Surgery from the Munich Heart Center in collaboration with Dr. De Silva here, that followed 20 patients with both pre- and post-operative CMR, and the median follow-up for these post-CMRs was just 11 months, so fairly early term or to midterm, but still very interesting data, and honestly, at the time, one of the biggest data sets that had both pre and post cardiac MRI data. So on this study, they found, if I can advance here, certainly the end diastolic volumes, you appreciate, on this upper right pane fell post-surgery, despite now the inclusion of that atrialized right ventricle. Meanwhile, the RV ejection fraction certainly trended down, which we expect, certainly, as you're incorporating this big volume and taking off all the preload that the TR was contributing. Another finding of this paper, though, was to highlight the increase in antegrade net stroke volume from that right ventricle, which again then serves as preload to the left ventricle, which is why we so often see that improvement in left ventricular filling and function after the cone operation. I'll jump us forward to 2018. This is a study out of Boston Children's Hospital from Dr. Barakim and colleagues in JCMR that again showed 20 patients with pre and post-cone cardiac MRIs. The median age at cone in this group was 16 years, and their follow-up was a median of 2.8 years, so a little bit further out than the last study. And again, you can see in their table, they had significant improvement in the TR fraction, drops in their right ventricular volumes, and note here that their RV ejection fractions were unchanged. There's a trend towards slightly lower post-cone, but really statistically unchanged. and then certainly increases in the left ventricular volumes and ejection fractions. They added an interesting spin to their analysis where they looked at left ventricular strain and particularly synchrony of all those segments within the left ventricle. And so you can see in this example patient in the upper pane, this was pre-cone, you can see pretty significant dysynchrony amongst those segments, most notably because of that septal dyskinesis. But in the post-operative study, much improved synchrony of that left ventricle. Again, moving ahead to 2021, this paper in JTCVS from the group at Great Ormond Street. This one had an average age at cone of 11 years, and only 12 patients had CMR data, both pre and post cone. But again, shows us this common theme of a dramatic improvement in tricuspid regurgitation, decrease in right ventricular size, and then an increase in left ventricular size and function. Again, variable change in the right ventricular ejection fraction. So again, no significance here. And then this, I like this kind of summary figure from this paper that again highlights the limitations of how we change the definition of the functional right ventricle that Dr. Yu brought up at the beginning, and how wrought that can be when we try to estimate regurgitant fractions before and after cone. But the trends stayed true in this cohort as well, where you can see this sustained decrease in tricuspid regurgitation. This study had some patients that had significantly more follow-up, and the TR remained quite low, whereas the functional RV area had improved, and as had the left heart area. And lastly, this paper, circling back to the Munich Heart Center, this one just from 2025 in the Annals of Thoracic Surgery, had a total of 46 patients. The majority of them were adults, but included some pediatric patients with both pre and post cone CMR data, as well as cycle CPET data. And this follow-up averaged around just shy of 7 years, so starting to give us more longer-term follow-up. The interesting part about this study is that they separated out 3 different groups, and I think this is really interesting as we see more and more Epstein patients coming through, that there really are different classes, and we know clearly there's different classes of severity in terms of valve displacement and how big these hearts are, but also separating out how functionally affected the patients are, I think makes a big difference as to how much of an effect they're going to have from the surgery, as well as how long it may take to see significant recovery. So there are 3 groups here, as you see in A, B, and C on the figures on the right, where Group A, New York Heart Class 1 or 2, without significant MR or ergometry findings. And they defined the significant MR findings as severe RV dilation, a significant recent increase in RV dilation, a greater than 40 milliliter per meter squared increase over the preceding 2 years, RV dysfunction, or peak VO2s on their ergometry, less than 65% predicted. So Group B here was, again, functionally quite well, but had significant findings on their MRI or CPET, and then Group 3 were, very low functional class. So you can see in the 2 panes to the right here, from pre to post-op MRI surrounding their cone, the least effective patients had not as great a significant change in their RV volumes, whereas obviously those that were most sick and affected are going to have the most dramatic decrease in their RV volume after cone. Whereas the change here in the net aortic flow, again, was greatest in the most affected patients in Group C, but was still significant in the 2 other groups. And then their other table, just looking at change in pre to post-operative RV ejection fraction, you can see here again, the smallest improvement in that ejection fraction was in those sickest patients. So starts to try to tell the story that maybe sooner is better to do the cone, whereas the most sick and affected patients, both by CMR and ergometry data, may take longer to recover or may not recover as well. Oops. So then taking this back to the patient I see in clinic, you can see here she's now 16 years of age, and on this MRI that was 2 years, the lower two panes was 2 years following her cone procedure. You can see that her RV ejection fraction was largely unchanged, but her TR was much improved, and her RV volume had come down considerably just in that short period. We continue to see on echo and intermittent MRIs that the free wall function is ever improving, but certainly takes its time. I should add that she also had a surgical RF ablation at the time of this cone, and since has been arrhythmia-free and is an active 16-year-old. So then just in the last few minutes, I just want to highlight a couple of interesting, again, very rare amongst our ever-growing cone population, but a few interesting cases. One is a 20-year-old woman who has been followed by our group for quite some time, who at 1 year post-cone, let's see if I can get these to play, perhaps. She had, thank you, she had just mild TR. Her RV volume had improved, as you can see, with a slight decrease in her RV systolic function, but improvement in her LV function. And then to everyone's surprise, she had these masses identified within the right ventricle, which were mobile and initially identified on echocardiogram, but then underwent CMR to help characterize and identify them. So you can see on the central pane in the coronal image that there were two, one larger and one smaller mass, mobile within the right ventricle. And on late gadolinium enhancement, we were able to confirm that it had the characterization consistent with thrombus. So she'd had significant workup after that, and with the help of hematology was found to have both factor V Leiden mutation as well as had been on an estrogen-containing OCP. She unfortunately had a small subsegmental pulmonary embolus and was treated for that, and has now had multiple follow-up imaging scans showing no recurrent thrombus following all that treatment, and is asymptomatic, working full-time. Actually had a follow-up CT this week that looked clean. So very unusual, but certainly brought up a learning point that maybe in young women particularly that may have other predispositions for hypercoagulability, it's notable to think about anticoagulation protocols following the cone. And then, oops, let me jump back one. And then an even more unusual case, this is a 37-year-old with the rare combination of bicuspid aortic valve, coarctation of the aorta, as well as Epstein anomaly. He had repair of his coarctation as a neonate, and now in his mid-30s was referred for cone repair due to progressive congestive heart failure as well as recalcitrant arrhythmias. And so he underwent the cone repair and biatrial maze. You can see on this short axis slice to the left, both the mitral valve opening, and here's the cone opening and coapting beautifully. On the forechamber to the right, you can see here's the cone itself. Again, that's functioning very well. But then you see this two-fro jet to the anterior kind of lateral side of the cone itself that appeared consistent with the dehiscence of the cone annulus. Here's the cardiac MRI that again kind of highlights this two-fro flow that's very anterior and kind of inferior around that annulus. You can see just a tiny trivial jet of tricuspid regurgitation through the cone there, and otherwise normal inflow just adjacent to that dehiscent area on both 4D flow images. And then from that MRI, we're able to use the 3D data set to build a model of this dehiscent area and understand exactly where it was located, even plan out a potential, cath course so that we could place a device within that dehiscent location. And that was done successfully with a follow-up MRI. He's now 2 years following the procedure. At the time of this scan, you can see the metallic susceptibility here from that little device around the annulus, but it did not inhibit the cone whatsoever. And on the, let's see if we can get this 4D flow to play, you can see, again, there's no stenosis of the cone, no insufficiency really, and it sealed off that little dehiscent area beautifully. He has now, after this device placement, has had significant interval decrease in his RV volume, had been 144 after the cone, immediately after, and is now down to 116 milliliters per meter squared. So it's had nice slope remodeling and improvement in his RV size and function. So with that, just to summarize, CMR really can aid in detection, decision-making, and interventional planning of, albeit rare, but cone complications. And long-term follow-up after the cone operation using CMR is really indicated to help us track this remodeling, which is a slow but progressive biventricular process. Thank you all.